Hello, so this is my first podcast, Mediculized podcast. This will be USMLE podcast oriented to USMLE step 1, 2, and 3. So let's first talk about gestational trophoblastic disease. So if they give in the scenario that the patient has gestational trophoblastic disease and now it's treated, the DNC is done, dilatation and curettage, and so now what is the next best step? So remember gestational trophoblastic disease, you should do contraception after that for the first 6 months after you treat the gestational trophoblastic disease. And the second thing is you monitor beta HCG until it becomes undetectable. So if they ask why you want contraception in the first 6 months, is because it will affect the measurement of beta HCG. If the patient gets pregnant in the first 6 months, let's say, it will affect the beta HCG levels. It will interfere with that measurements. And what do you need to measure beta HCG after gestational trophoblastic disease? And the reason for that is to look for the risk of choriocarcinoma. Normally, beta HCG after the pregnancy is over, beta HCG levels should fall. If, for example, if they rise again after the gestational trophoblastic disease, that suggests that it could be choriocarcinoma. Remember, choriocarcinoma can also occur after a normal pregnancy. They can give in the vignette that after the pregnancy, now the patient presents after 1 month with shortness of breath, and X-ray shows large lesions, round lesions. So that's actually choriocarcinoma that has metastasized. So it can happen after gestational trophoblastic disease, but it can also occur with normal pregnancy. So let's talk about another important scenario that they give is uterine atony, which is postpartum, most common cause of postpartum hemorrhage. And so if they give uterine atony, and let's say they say what is the next step? So first you do the uterine massage. After the uterine massage, if that doesn't help, then you do oxytocin, and if that doesn't help, then you give something called methylargonavine, or you give carboprost. But remember, be careful. Here in the vignette, if they say the patient is hypertensive, so avoid methylargonavine. And if in the question vignette they say that the patient is asthmatic, then avoid carboprost. So this is how they test. In the question, always look for those two things. And if either of those present, just give the relevant drug. Methylargonavine, don't give in hypertension. Carboprost, don't give in asthma. So let's say they give you then another scenario that there is vaginal bleeding in third trimester and it's painless. So that's placenta previa. Placenta previa is just placenta overlying the cervix. It covers the cervix, and that causes the bleeding. So remember, if they say gestation is early, let us say 16, 10, 11 weeks gestation, you get placenta previa. So you just do follow-up ultrasound. You don't do anything about that. But if they give you like really late gestation, like 35 weeks gestation, then in that case, you have to do something. So there are certain things that you should look out for. Like you should counsel the patient that digital cervical examination should not be done. Like if you, let's say, see in ultrasound that there is a placenta previa at 30 or 35 weeks gestation, then obviously you shouldn't do digital cervical examination. Second is counsel the patient that they should avoid sexual intercourse, because both of those things can, because if you do sexual intercourse or digital cervical examination, because the placenta is over the cervix, so it can damage the cervix if you do those things. If they say that speculum examination can be done in placenta previa, so the answer is yes, you can do speculum examination, because it doesn't actually enter the cervix and affect the placenta. So that was placenta previa. If they say there is a third trimester bleeding that is painful, there is painful abdomen. So remember, that is placental abruption. And for the placenta abruption, remember that usually vaginal bleeding will be there, but in 25% of the cases there is a concealed hemorrhage. The hemorrhage is just behind the placenta and you can't see it, but the patient still will be hemodynamically unstable. So you should still treat the patient and stabilize the patient and then deliver. So that was placenta. And remember, the risk factors for placental abruptions are important, like smoking. Smoking is one. Cocaine, preeclampsia, hypertension. So those are all high yield. Now for preeclampsia, remember the it should be greater than 20 weeks, and it's the blood pressure greater than 140 over 80. And plus there should be proteinuria or signs of end organ damage. So this is the scenario. This is the criteria for preeclampsia: greater than 20 weeks gestation, greater than 140 over 80 on 2 readings, on 2 separate occasions, and plus there should be either proteinuria or signs of end organ damage. Proteinuria is remember, usually should be 2 plus on the dipstick. If they say +1, that's usually not proteinuria. So proteinuria. And what are signs of end organ damage? So that's important. Signs of end organ damage, you just need, there are 2 types of preeclampsia: preeclampsia without severe features, preeclampsia with severe features. So with severe features, you get signs of end organ damage. Any one of them, if it's present, then you term that placenta with preeclampsia with severe features, like platelets less than 100,000, like creatinine greater than 1.2, like pulmonary edema, right upper quadrant pain, stroke-like features. These are all high-risk features. Severe headache is, and if they say the mechanism is that there are spiral arteries, and usually the spiral arteries are long and coiled, but in pregnancy with preeclampsia, they are narrow. They don't develop normally. So there's placental ischemia, and placental ischemia results in generation of angiogenic factors that actually spread through the circulation and cause endothelial damage and vasospasm. Endothelial damage leads to platelet microthrombi formation, similar to hemolytic uremic syndrome, thrombotic TTP. So those are similar mechanisms. So that's why you get thrombocytopenia as well, because of the binding of the platelets to the endothelium. So these were something about the ObGyn stuff. Usually helpful a lot for both step 1 and step 2 and step 3. So hope this video was helpful, and if you liked it, please like and subscribe to the channel.